Good afternoon, everybody, and welcome to our session on recent advances in ocular malignancies. This is the very first IC I have ever done in my life, and the brainchild, this IC is the brainchild of the person sitting to my right, Dr. Sharika. And the strength of the IC is obviously a person I've known as a postgraduate, as a fellow, and finally as a full-fledged, very, very compassionate, caring, and competent ophthalmologist, Fairuz. And I'm truly blessed with the other faculty that Sharika chose the topics, Sharika roped in the people. I was only asked to ask Fairuz, and Fairuz readily agreed. Sharika believes it's because of me, but I know it's because it's Fairuz, and she loves to tell us about retinoblastoma. So we'll go into the session right away. And the very first talk is by Fairuz on retinoblastoma, diagnosis, treatment, and long-term outcomes. And let me remind you that she's the best person to talk about this, having years of experience of bringing people who were virtually blind with retinoblastoma back to seeing. Over to you, Fairuz.
Thank you. Thank you so much, ma'am, for this kind invitation. Thank you, Sharika, for putting this session beautifully well. And I'm very candid here. Dr. Patmaja holds a very, very great, space in my heart, right, as a postgraduate student. I remember her coming as an examiner, and I was given the responsibility to take her around in Mysore. And that's where we vibed and connected, and that relationship has been continuing. And she's really, really inspiring. She's one of the inspiring person in my life, and I owe it to you, ma'am, for everything that you have been encouraging me so far. And thank you today for having me here. Okay, going on to the topic, retinoblastoma, again, something which is very close to my heart. In the next 10 minutes, I'll try to cover because it's diagnosis, management, and outcome. Now, to treat retinoblastoma, it's just not me. I give the credit. It takes a village to treat a retinoblastoma patient. I, being an ocular oncologist, is supported by a medical oncologist, a radiation oncologist, neurointerventional radiologist, pathologist, without whom nothing happens. And whatever I'm presenting here today is all because of the studies that we could do, and thanks to the parents and, of course, the babies and my mentors who have led me through this journey. My main work in retinoblastoma is at Malabar Cancer Center in Kannur, Talsheri, where we have everything from the laser to the plaque brachytherapy, site care cancer hospitals with the oncologist that I'm associated, and Kidwai in Bangalore. So the most important thing that I want to highlight here today is it's happy news. Retinoblastoma is a good disease. It's positive. It's a curable eye cancer in more than 98%, and most of the time we forget about that. But the main issue is there is lots of challenges, and we need to close the care gap. It's basically we have to make it accessible, affordable, and available. And unfortunately, this disease is seen in the lower economic strata where they need a lot of financial help from people like us. Now, what I'm going to highlight here today is how to identify the disease. I know everyone knows about retinoblastoma, but this is mainly aimed to those who are new into ophthalmology, applying the grouping, applying the staging, the treatment strategies, and finally the outcome. Most commonly, it's easy. White reflex, any child coming with a white reflex or a parent having a suspicion of a white reflex, it's mandatory to examine the child detail with the dilated fundus evaluation. Now, this child, a small boy from a Muslim family in Bangalore, they detected a white reflex. So, दादी ने बोला कि आंख में चमक है कि बच्चा स्पेशल पैदा हुआ है, it's a special child, there is a twinkle in the eye. So they sat with it. All right, so we have certain social beliefs in India. It's just not India, even in China, during my experience, where people ignore about it. When you have a squint, some people think, oh wow, it's a mark of beauty. Let the squint be there. It's luck factor. And these things still happen. We don't have to be amazed about it. But when we looked inside his eye, this is how it was. It was an endophytic RB completely filling the eye. Well, we didn't have any other way but to enucleate. And well, the child is happy, the parents are happy because he was rehabilitated with a prosthetic eye, strabismus. Any child presenting with the strabismus definitely needs a dilated eye examination. Now, the logic is very simple. We have a posterior pole tumor, might be covering the macular area, the posterior pole. There is no vision, so it's a vision deprivation squint that the child has it. So any squint child has to be evaluated. Cataract, straightforward white cataract, all right? Yes, perfect. But what caused the cataract? A tumor behind the eye can cause a cataract. Ultrasound B scan is a must. So there is a calcified lesion intraocular with high spikes over here. Now, it is a masquerade. It can trick us. Retinoblastoma is not easy sometimes. It can really trick us. Unilateral glaucoma, unilateral ophthalmos, hyphema, hypopaeon, even phthisis bulbi. You have to ask for a history of, an orbital cellulitis like a picture in a child where the eye has gone for phthisis. Tumor necrosis, phthisis bulbi. So these are the different masquerades in retinoblastoma. A child, all these things, any problem such as these things, unilateral, always retinoblastoma or any other intraocular malignancy like ciliary body medullary epithelioma has to come into your mind. Now, how do we diagnose it? It's simple. Retinoblastoma is a clinical diagnosis. The other tools that you have are additional armamentarium. The most easiest thing that most of the clinics in the hospital has is an ultrasound B scan, which is good enough to diagnose a retinoblastoma intraocular. Examination under anesthesia is very, very important. Just don't see the posterior fundus and see, well, there is nothing there, but it's so important when there is a suspicion, take these kids under general anesthesia, examine 360-degree aura. It's just not aura. I don't stop at aura. I even go and see the ciliary body because there might be a child coming with hypopaeon where the entire fundus is normal, but you can find these tiny seeds in the ciliary body. Even that much, depression and examination has to be done, well documented, because it's important for grouping, staging, and the further follow-up in these children. We have the international classification of intraocular retinoblastoma. I'm not going into the detail. This is for the postgraduates. You have to go and check it out. It's from A to E. Then we have the TNM classification. Now, what is important about TNM classification in retinoblastoma is that we have H. The hereditary component is the only cancer in the entire AJCC which holds an H, because retinoblastoma is a genetic disease, and that's how we actually emphasize the importance of hereditary in retinoblastoma. Now, going on to the treatment, well, we have primary treatment modalities and secondary or adjuvant treatment modalities. The primary is just 3, I would say: systemic chemotherapy, intra-arterial chemotherapy, and enucleation. Now, another variant of chemotherapy is the intraocular chemotherapy, which is not a primary modality, but it's just an adjuvant chemotherapy after you give the primary modality. Rest are laser, cryotherapy, and plaque brachytherapy. As I told you, systemic chemotherapy, intra-arterial chemotherapy is the advanced, newer modality of treatment. Systemic chemotherapy has, excellent outcome when it takes care of the systemic micrometastasis as well, whereas intra-arterial chemotherapy has the advantage that the chemotherapeutic agents are directly pushed into the tumor, so the outcome is better as far as group D eyes are concerned. Now, transpupillary thermotherapy is an adjuvant treatment where you chemo reduce the tumor size. When you have something active, you just go and treat it. So this is the fovea sparing transpupillary thermotherapy. With the diode laser, the damage to the retina is much less than a green laser. So that's why I use in my practice. Now, this is a patient with a peripheral lesion which was cryoed. Rest of the things, everything is done. This is after cryotherapy and intravitreal topotecan injection, completely regress. This is a recurrence after treatment with systemic chemotherapy, cryotherapy, and intravitreal topotecan 3 times. So with the advent of intravitreal topotecan, I have started combining these with either with laser or cryotherapy, because I feel once the tumor is stimulated by a laser or cryotherapy and then putting a chemotherapeutic agent over it really helps in the response. And I found that difference in my practice. 10-year-old boy, bilateral hypopaeon, 6 chemos completed elsewhere. They said he might have to go for bilateral enucleation. That's when the parent came to me. This eye is already phthysical. So my challenge here is to save at least one eye. That is the right eye. Now, his fundus is perfectly fine. Okay, posterior fundus is fine. Periphery is good, as you can see here, only scarring. What he has is this ciliary body particles. And it's just not here. He has everywhere. He even has superior. And this is what is spitting into the anterior segment every time. When you look, everything is silent in the posterior pole, but this is what he has. So I had to go ahead with 8 intravitreal. Okay, what happened? Gone? Yeah, thank you so much. So the child, what I had to do was, yeah, I'll just quickly take it. Yeah, so 8 intravitreal, what? Yeah, even it's going off here. I'll tell you the story. So he received 8 intravitreal topotecan. He received 3 intracameral topotecan in the same eye. Then he had a ciliary body component inferior, which we had to give plaque brachytherapy. And after plaque brachytherapy and these intervention, he developed a cataract. And then we have to go ahead and do a cataract surgery. And well, we were kind of, 1 second. Oh, when we are taking that picture, that slide, no? Then we'll skip that slide? Okay. I'm sorry. Okay, let's skip that slide. 1 second, no? I know this slide, yeah. This slide also? Yeah, I'll just, is it same? No, the previous slide is the one, culprit. This is okay? Yeah. So this is how he was finally with a 6/24 vision in the right eye. Crossing fingers, mashallah, hope he goes like this. With 5 years follow-up, he's doing fine. Anytime they can recur. Oh. No, not that one. I'm so sorry. Something is... Can I do the next one? Oh, I'm so sorry. Will it play? No, it's not playing anymore. It is not keynote, it's PPT. Maybe the next person want to present, I can take it later, ma'am, without any delay. Yeah.
Maybe
Yeah.
do that. Then I'm sorry if I rose.
That's okay.
I hope it gets sorted out. So we go on to the next talk on ocular surface squamous neoplasia by another very good friend and effective speaker, Dr. Vijayalakshmi from Comtrust, Calicut. Can we have the next?
A very good afternoon to all of you. Yes, thank you, Padmaja ma'am and Sharika, for having me here. I'm a little apprehensive talking about OSS in front of Dr. Fairuz, the maestro in OSS. Madam, with your permission, I'm going to OSS. As we know, ocular surface squamous neoplasia refers to a spectrum of disease ranging from mild, moderate, severe dysplasia to invasive carcinoma originating from the limbus, cornea, or the conjunctiva. It has this histological picture showing from mild to carcinoma in situ and the keratin pearls. Now, there are certain risk factors for developing OSS. One is the exposure to ultraviolet radiation, human immunodeficient HIV infection, HPV, chronic use of contact lens. Any chronic trauma chance of OSS is there. Similar to exposure to petroleum products, some fumes. There is a genetic predisposition and heavy cigarette smoking, as well as male gender in certain areas also. Now, carcinoma in situ, 39% of all pre-malignant and malignant lesions of conjunctiva is carcinoma in situ, and OSSN is the most commonly encountered non-pigmented tumor of the ocular surface. So it's very important you have to diagnose it early and treat it. So these are some mimickers seen in these are some mimickers. This is keratoconjunctivitis. This is a pyogenic granuloma or a foreign body granuloma picture. This is a pinguicula. Here you have the pterygium, and again palpebral form, limbal form of VKC. So all these can be mimickers of OSSN. Now, how do we distinguish them? How do you diagnose this? One, from the history, whether it is papillomavirus infection, exposure to UVB, smoking, contact lens, as I mentioned earlier. And if you get a young patient with HIV, always screen them, young patient with OSSN, screen them for HIV. Now, once we have got a patient, suspicious patient, do a thorough slit lamp examination. ASOCT, if an access to it, go for HROCT and UBM. In doubtful cases, you can go for biopsy. Now we don't do much of excisional biopsy, and we have the impression or exfoliate cytology, but it's not very conclusive. But in case of inflammatory pathology, you can get some inflammatory cells in this. Always check for the regional lymph nodes. That's very, very important. And now this HROCT showing, you can see the hyper-reflective epithelium with the thickening and the abrupt transition at the normal and abnormal epithelium. That's very, very important. HROCT for diagnosis and as well as managing OSSN. Now, there are certain characteristics we have to think when you see a case of OSSN. One is the presence of keratin, feeder vessels, intrinsic vascularity, and the pseudopodic-like picture on the cornea, as well as rose Bengal staining, where you get staining of the devitalized tissues also. Now, there are different morphology of OSN, from placoid, papuliform, with different pictures showing different variety, like strawberry-like lesion, and you have the gelatinous type, placoid, corneal OSSN, nodular, mucoepidermoid, and diffuse OSSN. So these are the various variety of morphological patterns of OSSN. Now, how do we manage? Suppose it is localized or diffuse or invasive. The management is different. When it comes to localized, you can go for topical medical therapy. Diffuse, again, you can go for medical therapy, because diffuse, when it is difficult to do a large area of excision, it can result in limbal stem cell deficiency. Again, when it comes to invasive, the treatment is first we can go for chemoreduction, surgery, and may require radiotherapy also. So these are the different modalities of management. Surgical excision, medical, we have the interferons, MMC, 5FU, and adjuvant therapies like anti-VEGF, topical cidofovir, topical retinoic acid, and PDT. So what we do is, when we manage this patient with topical topical immunomodulators, we also add retinoic acid, which we use in this Inflomax. Now, gold standard for management of OSSN is Shields no-touch technique with 4 margins of clear-free tumor zone, and we followed by intraoperative cryotherapy with a double freeze and slow thaw technique. Is very, very important. Again, if there is a corneal component, you'll have to go for corneal epithelectomy using absolute alcohol, and in case of adherent tumors, you'll go for 20% sclerectomy. Wound closure is done with amniotic membrane using a fibrin glue. As I mentioned earlier, complications can be limbal stem cell deficiency, symbliphron formation, congenital hyperemia, and scarring. With Dr. Fairu's permission, I'm playing this video. See, you can see the tumor area is marked here, 4 millimeters, tumor-free area. Intraoperative OCT is there, and no touch technique, you're removing the tumor, and this alcohol epithelectomy. And the main important thing is, after doing the surgery, slow thawing, freeze, double freeze thaw, slow thawing is very, very important to the undersurface of the conjunctiva. And this followed by amniotic membrane grafting and using a fibrin glue. But after this, that mapping and sending for histopathology is very, very, very important. You must mark it either on a filter paper. We usually use a suture, sponge which comes on, which we anchor the tissue, mark it nasal, temporal, up, down, base, everything you have to mark. Because when the histopathology report comes, very, very important, is the margin free or the base free? That is very, very important, and the management depends on that. Suppose there's an ocular invasion, you have to go for enucleation. And in case of orbital extension, you'll have to think about orbital accentration. And these are the medical management molecules we use: 5FU, interferon, and MMC. Initially, we used to use lots of MMC, but now we have moved on to interferons and 5FU. The good thing about medical management is it treats the entire ocular surface, and the subclinical cases can also be dealt with. Now, this 5FU, we give in a dose of 1%. 4 times a day for 1 week, is followed by 3 weeks of no medication. And another one thing you have to explain to the patient is always apply Vaseline around the eye or some moisturizer, so that the extravasation or spilling of the drops won't produce any necrosis or excoriation to the skin. This patient had forgotten to use it in 1 cycle, and this is what happened. Again, coming to interferon, it's given a compound in 1 million international units per ml, again given 4 times daily till the tumor resolved, and further for another 1 or 2, 3 months. Good things about it's well tolerated, but the difficulty with this is very expensive and it had require refrigeration also. It can be given intralesion also, and we have seen flow-like syndrome in patients. Compounding of interferon, we draw 1 ml and we mix with 5 ml of the lubricating agent, reconstitute, label it, refrigerate it and give it to the patient. That's very, very important. Now we have switched, as I said, switched to FFU and interferon. MMC, we don't use it that much because the stinging and redness, allergic conjunctivitis we have observed is more with MMC. Now, combined medical and surgical management is indicated when, that is when you have large tumor, we require a chemo reduction. Give the medical management followed by the surgical management. And after the surgery, I have the histopathology report. If it is base positive, we have to think about radiotherapy. Now, this is a patient seen in our hospital, 75-year-old female. She had come with the gelatinous mass there, and we started her on interferon, and the lesion resolved within 3 months of treatment. It's another patient who came with, again, a gelatinous mass at the limbal area. But initially, the patient didn't respond to interferon. Then the patient came with a result that a history of antiretroviral therapy. Thing is, the patient should be immunocompetent when you have giving interferon. Immunocompromised, the efficacy is very, very poor. So we switched to FIFU and the lesion resolved. As a case 3 again, this patient had undergone cataract surgery, and on the table, the surgeon suspected a lesion there and sent it for histopathology, and it was CA proven case of OSSN, and this patient started on interferon. But in between, patient developed uveitis. So that's immunity is changed in that patient. In that patient also, we had to shift to 5FU. It's a corneal OSSN, again resolved completely with the interferon treatment. Again, diffuse OSSN, if we go for a surgery, this can result, as I said earlier, in a limbal stem cell deficiency, large area of conjunctival sacrification, you get result in symblepharon and scarring also. And this patient responded to interferon, and that's 2 months after treatment. Again, a patient with corneal and limbal OSSN responded well to this HROCT picture. As I said earlier, you can see the abrupt transition from normal to abnormal. So, detect early, treat appropriately. Thank you.
Thank you, Vijay. Thank you so much. With all apologies to Fairuz for what happened earlier, I think we will let Fairuz complete and take questions at the end, time permitting. While Fairuz, with fingers crossed, gets her slide to play, if there are any questions, Vijay is willing to take them.
Excuse me. How do you decide whether you have to do a complete excision with 4 mm margin? And in some cases, you did give only interferon, no?
Initially, we used to do, for the past 4 years, I have not done a case of. That is off the top by our
Interferon and all.
Ma'am, when we talk about interferon, we say it is expensive actually, but actually it's not that expensive, right? Don't you think so? It's 1,200 rupees, right? And compared to 5FU, of course, compared to MMC. In United States, actually interferon is $250 US. So compared to that, it's actually very cheap that we get, so yes. I think we should not shy away from it because the side effects are hardly anything. So, yeah, right. I'm so sorry about this technical thing. I'll quickly take it through. Yeah, so basically coming to the outcome, we have very good outcome in Group A, Group B and Group C. Now the difficulty is in Group D because we have extensive vitreous disease, diffuse vitreous disease, and Group E, of course, there are certain Group E's we can save still, but most of the Group E's goes for enucleation. Now this is a Group D disease, extensive vitreous disease, as in this case. Systemic chemotherapy was given 6 times, periocular topotecan, intravitreal topotecan. Then she had the ciliary body component still still there, which was given plaque brachytherapy. And finally, this is the outcome after all these combination of treatments. So combination of treatment in retinoblastoma, you have to actually make a cocktail and do it. Group D again, systemic chemotherapy, periocular, intravitreal topotecan, and this is how this eye was saved, because this was only the eye which was seeing. Now, group D with intra-arterial chemotherapy has excellent benefit. It is directly into the eye. This is after intra-arterial chemotherapy, 4 sessions and intravitreal topotecan with a diffuse seeding that you can see there. Group E eyes, intra-arterial chemotherapy, systemic chemotherapy 6, cryotherapy and transpupillary thermotherapy. Well, there is no significant vision in this eye, but for a parent, even salvaging an eye is a big success. Group E eyes, intra-arterial chemotherapy, intravitreal topotecan. Now, the youngest that I have treated with intra-arterial chemotherapy is 4 weeks of age, where the tumor was detected when the child was in the womb of the mother by a gynecologist, referred, and intra-arterial chemotherapy for the right eye and left eye. This is right eye, and left eye small tumors were treated with laser. Outcome of intra-arterial chemotherapy when you compare to chemoreduction, group D eyes has a significant outcome, 94. Topotecan, we have eye salvage of 90% in these patients. Now, this is a patient with anterior segment RB, plaque brachytherapy over it, and the eye was saved. So, plaque brachytherapy can be primarily used or secondary in recurrences. Enucleation in extensive, but enucleation is not the end. Histopathology has to be done to look for high-risk features for adjuvant chemotherapy. Extraocular extension with intensive multimodal treatment protocol, we have got a success rate of 95% survival, not about the eye salvage. What you need to realize and recognize is any patient who comes with you, you have to educate them and counsel them that their kids have to go for an early screening, and every child in the family, maternal or paternal, has to go for a screening. So take home message, again, it's a curable eye cancer. Everything is a good news in retinoblastoma, and we are actually advancing in the genetic front as well. Thank you. Life is definitely precious, but with the advanced treatment and modern modalities, we have reached to the point where we are trying to save actually many eyes. Yeah, thank you so much.
Thank you so much, Fairuz. We now go on to the next talk. One of the themes of malignancies in the eye is that they're great masqueraders. And one of the biggest of these is the intraocular lymphoma. And our speakers, we have Dr. Prakash to talk to us about the challenges. And truly, there are many in both the diagnosis and management. And one of the things our session is all about is that malignancies are not either the end of vision or end of the eye. And the kind of results that Fairuz has shown us with advanced retinoblastoma, where in my day, they all ended up with enucleation, is truly admirable. So to diagnose and treat, like Vijay is saying, earlier OSS said, chop it off, now no, treat it medically and preserve the conjunctiva. Over to Prakash.
Thank you, ma'am, and good afternoon to all. So intraocular lymphoma is actually a subset of primary CNS lymphoma, and it is, as madam told, one of the commonest masquerade. It masquerades as uveitis, especially in elderly females 60 to 70 years of age, and usually it's a bilateral disease, and it's a B-cell lymphoma, even though T-cell lymphomas are reported. And usually it originates from the retina or vitreous, and that's why it's also called as PVRL, even though there is a few subset which originates from the uvea as well as optic nerve. And also there is secondary lymphoma, which is lymphoma comes from the systemic into the eye. So that has to be differentiated from the primary lymphoma. And if you look at the CNS lymphomas, if they are followed up, intraocular lymphoma develops in about 10 to 16% of cases only, whereas if you follow up intraocular lymphoma cases, nearly 70% of them develop CNS lymphoma. So what it translates to is that it's the onus of ophthalmologists most of the time to diagnose this disease so that a life-threatening as well as a blinding disease is treated in time and saved. So the challenges and the clinical presentation, I'll just go through some illustrative cases. So this was the first case. Actually, at that time, we were not, even though we have read about lymphoma, we were not seeing. This was almost 10 years back. This 65-year-old gentleman presented to us. He had already undergone 2 renal transplants, and he was on triple immunosuppression and had been treated on bone TB, All these things made the diagnosis very difficult for us initially, and we were seeing for the first time the lymphoma, intraocular lymphoma. So these were the lesions, creamy yellow lesions all over the fundus was seen. So the first diagnosis was CMV retinitis, given his immunosuppressive, and straight away started on ganciclovir. But due to the atypical presentation, we did a vitreous tap and sent it for PCR for other viral as well as toxoplasma as well as TB. Only toxoplasma came as negative, and CMV was toxoplasma came as positive, and CMV was negative. So we added anti-toxoplasma also. And even that time we didn't do a biopsy, but 5 days later he presented with further drop in vision. The lesions had grown extensively. At this point of time we thought this could be something else, and we did by this time he actually developed a retinal detachment also, so it made things easier for us. So I did a vitrectomy, removed all this material that you are seeing on in front of the retina. And actually, since he had an RD, I could take some subretinal material also, made a drainage retinotomy and remove this material also. And this material, these are very less coercive. They just come when you aspirate, you can see them flowing into your aspiration needle. And immediately it was sent to the cytopathologist, and it was processed immediately, and we could see atypical lymphocytes, and it was diagnosed as primary intraocular lymphoma. Evaluated by oncologists, there was nothing systemic that they could detect, and they didn't start him on any systemic treatment. That's one of the challenges which I will come into later. So this patient we treated with intravitreal methotrexate. At that time we were not aware of the correct protocol also. We injected monthly intravitreal methotrexate. It responded well actually, and I gave it for almost 1 year, and the patient after in between he underwent silicone oil removal, and at that time did a cyto again. It was negative. But this patient again presented to the systemic due to CNS lymphoma, and he passed away. The second case again referred to as a probable sarcoid uveitis had a this was a lesion in the left eye. You can see this multiple creamy white lesions. Right eye also had 2 or 3 lesions. So by this time we were wiser, and we knew this was primary intraocular lymphoma that we are dealing with. And the OCT, you can see the OCT is very diagnostic of this condition. You can see sub-RP lesions which are homogeneous. This homogeneous appearance. Many times you see subretinal also, and so these lesions are very typical, and we gave intravitreal rituximab for this patient. And she actually refused systemic treatment in spite of me sending to 2 different oncologists. She refused systemic treatment, and later she was admitted with CNS lymphoma. I don't know what is her condition now. So this was a third case, a younger lady, 56-year-old, presented with some blurring of vision. This was her left eye fundus. You can see these creamy white lesions in the mid-equatorial region. Again, this was very typical of lymphoma. We straight away did the angiography. So the right eye was not involved. There was few RP defects, but there was no lesion in the right eye. Left eye shows angiography shows mixed hyper and hypo areas. And the OCT again, you can see it is very typical. This sub-RP homogeneous material under the RP with RP bumpy looking RP. And also you can see the even inner, when it involves, even it can involve the inner retina also. When it involves even inner retina, looks homogeneous in appearance. This area you can see. And this is a fundus autofluorescence which showed a patchy hypo. ICG showed a blocked fluorescence. So straight away we actually did, since this patient was very apprehensive, I actually decided to do a biopsy, as well as at the same time I gave an rituximab with injection methotrexate. To my surprise, actually the patient developed sudden drop in vision, and there was a CRA kind of picture as well as a retinal vasculitis, and there was large RP rips at the site where the lymphomatous lesions were there. I don't know whether it was a dramatic response of this lesion. I started this patient on oral steroids, and vision improved to 636 over a period of time, and the macula, you can see the lesions healed well, and the atrophic areas where the RP rip developed also can be seen. That eye became completely, she underwent multiple intravitreal injections of rituximab in that eye. Systemically again, we even though referred due to lack of specimen, lack of this thing, by many reasons she never could undergo a systemic treatment. And recently I saw her with cataract in that eye. Vision had dropped to 1/60. I was about to advise cataract surgery when I looked into other eye, and other eye is again the same type of lesion which she had in the left eye at this point of time. So now this is actually a retro mode imaging which is seen in NIDEC, which this imaging modality I was thinking it was useless, and I was not at all using this. But in lymphoma I saw that these lesions are very well seen, much more than any other modality in, so just thought I'll show. So this is the other eye OCT also, similar lesions. So OCT is the most diagnostic thing. So this is again one more case. This patient actually 4-5 years back, this is a photo 4-5 years back. She had come to us with recurrent anterior uveitis, many recurrent, and vitreous haze has been noted, but nothing else has been noted in fundus. And she had actually undergone, due to recurrent nature of anterior uveitis, she had undergone actually fluorescein angiography, which had this kind of leopard spot appearance in the fundus and some active leaking hyperfluorescent lesions in other areas. So that was her picture, and then 4 years later, she had in between 2 years, there was no follow-up from this patient. Then she came back with this lesion in the right eye fundus, large lesion in the fundus, and by OCT again you can see this has involvement of sub-RP as well as overlying retina. Again you can see that homogeneous lesions all over the retina. So we were diagnosed straight away it as intraocular lymphoma, and biopsy confirmed diagnosis. And this is after multiple injections of intravitreal rituximab. The lesion resolved well with atrophy of retina, but vision didn't improve for that patient. This is the reverse. This was a patient who was already on treatment for CNS lymphoma, who came to us with drop in vision and had this typical lesion. She was a very sick patient. We couldn't do anything further for this patient. So this is CNS lymphoma presenting with ocular symptoms. So the main thing is the vitreous biopsy in these patients. Most important step we have to do is getting an undiluted specimen of vitreous, and if possible I prefer to, if at all there are lesions, I try to take retinal lesions also. Nowadays I straight away start with under air. The vitrectomy is done under air, so I get maximum undiluted specimen, because for flow cytometry they are asking almost 4 cc of fluid, which you will get only if you do the surgery under air. So this is surgery being done under air. Straight away start with the infusion cannula under air, and this is the subretinal. You can see the subretinal material that also can be taken to add yield. The problem is these cells are very viable. Unless you transfer this specimen to the pathologist within an hour, you are not going to get it positive for lymphoma. So the quick transport is very important, and we have the problem, we have a lab very nearby, but the oncology people won't take the result from that lab, they want their own result. So that is almost 2 hours from our place, so we find it difficult to transport to the oncology center. One patient has not received systemic treatment only because of that. So now what we are doing is we are cooling the specimen to 10 degree and sending. Then our yield has increased even in the oncology. Even after 2 hours we are getting positive lymphoma specimens. You cool it for 30 minutes to 10 degree and send the specimen. So that increases the yield of the cells. So other studies are, the most specific is supposed to be the IL-10 bar IL-6 ratio, but nowhere in our place IL-10 is being done. IL-6 is possible. Then you have the PCR for MYD88 mutation, that is actually does not require large amount of specimen, unlike flow cytometry or the gene rearrangement study. Both flow cytometry and gene rearrangement studies require large amount of specimen. So that's again one more challenge, getting the large amount of specimen that is required, as well as transporting in time. So again, treatment over a period of time, we have modified our protocol. Now the intraocular treatment is with IV methotrexate or rituximab. Which is methotrexate is given in an induction dose weekly, twice for the initial 4 weeks, then weekly 8 weeks, and monthly for 9 months, or rituximab weekly for 4 weeks, and then monthly is being 3 weekly we are giving. So systemic treatment also is very important in this patient, because we have seen when you evaluate the first time when the patient is having the ocular problem, most of the time CNS lymphoma is not at all diagnosed. Even CSF study, bone marrow, everything is being done, but nothing, you cannot diagnose systemic. Then one day patient presents with the systemic complaints, and then it is beyond salvageable. So that's a problem. So prefer to start systemic treatment as soon as we diagnose intraocular lymphoma. And the prognosis, 90% of them develop some point of time CNS disease, and the survival rate is not very great. And one study shows sub-RP infiltration is associated with shorter mean time to death. So just treating ocular problem alone does not increase the survival of the patient. It's important to have systemic treatment also. So we should remember this disease, and that is whenever you have a patient who is presenting with uveitis, and especially if the patient is elderly, should always think of is it lymphoma. OCT will be the most important diagnostic tool. So earlier treatment, and if you do a vitreous biopsy, you can easily diagnose that, provided you send the specimen very quick and get your pathologist. I keep the pathologist ready there to receive my specimen, otherwise you don't get this positive. Thank you.
Thank you so much, Prakash. We'll take questions at the end. We'll go on to the next one. So we've done with malignancies in and around the eye. And now we go to what happens when you have metastatic disease into the eye. So these are no longer primary malignant tumors. The other thing I was thinking while Divya gets ready with her talk is that all of us base our prognosis on what the literature says. And it's so often defeatist because whenever I think of intraocular lymphoma, I think of death. I never think of people surviving. And when I think of retinoblastoma, my patients have survived, but with enucleation. So I'm sure that over a period of time, with all the work that is going on, including by all of you, the future generations will no longer see these as absolute harbingers of death or blindness.
Okay, thank you very much, Madam and Sharika, for giving me this opportunity. So my talk is about metastatic ocular tumors. So what is a metastasis? We all know the spread of cancer from the place where they first form to another body part. So the eye as such is a very rare site because there is less lymphatic, there's an absence of lymphatic system, and it spreads by hematogenous spread, and the parts of the eye which have the most vascular supply are affected. And thus the most vascular supply in the eye is the uvea, and the uvea is the most common site, and in the uvea the choroid forms the major part. So mostly I'll be talking about choroidal metastasis, first documented in 1872, but now it is the most common intraocular malignancy in adult population. And the primary source is a breast cancer most commonly, and followed by lung cancer. And when there is no primary site, and the workup will ultimately more commonly lead to a lung cancer. So the pathophysiology is hematogenous dissemination of tumor cells. The posterior ciliary arteries in the eye provide great flow for tumor emboli, and they are the most common causing posterior choroid metastasis. So pathophysiology mechanism, there are multiple theories proposed: the anatomical mechanical mechanism, seed soil mechanism, and the wound oncogen wound healing model. I'll just go through them. The anatomical model says that the first anatomic site, which is downstream of the primary tumor, has the higher frequency of metastasis. So in the eye, the posterior ciliary arteries causing posterior choroid having more metastasis. The seed soil mechanism says that the seed, that is the tumor cells, should need an adequate microenvironment, and this microenvironment is provided by the organ with the most vascular supply. The wound oncogen model is a new model where they say that the cancer is a result of the attempt of the body to heal a wound, and this abnormal wound are the oncogenes which get activated, causing metastasis. So signs and symptoms of metastasis patient generally presents with blurred vision. They can also have flashes, floaters, or occasionally pain, and very rarely they have no symptoms and are just found out on routine ocular examination. So they are generally appear as creamy white, pale yellow masses, subretinal lesions. You can see the retinal vessels over these lesions. They are all subretinal. Their appearance is flat or plateau shaped. We can sometimes think about the primary on looking at the morphological features of these. Like in the first picture is of a lung carcinoma where it appears pale yellow color. For breast cancer, the metastasis may appear like lobular. And last is the prostate cancer where it can be seen as a melanotic mass. Sometimes they also present similar to a lymphoma, like with the leopard spot pigmentation. They can be bilateral, they can be multifocal. Then laterality has also been debated in multiple studies, where they say that the left eye was more commonly involved because it has a more direct pathway to the eye from the aorta. So the main thing when you see these choroidal masses is to differentiate them, whether they are malignant or whether they are benign. It can be a malignant melanoma also, or it can be benign tumors like an osteoma, hemangioma. Even a CNVM can look like a choroidal metastasis. The most common feature which is seen with this is subretinal fluid. In contrast to a melanoma has to become very large, very huge to have a exudative retinal detachment, where here even smaller lesions can cause subretinal fluid. Multimodal imaging, of course, comes to our help, where fluorescent angiography and ICG can be done. The top pictures are of the fluorescent angiogram, where the fluorescence will show stippled hyperfluorescence with minimal leak. ICG is generally seen as a hypocyanine lesion. But this multimodal imaging may not, just the angiogram may not help us in differentiating them from melanoma or other tumors, because all of them will appear hypo on ICG. The B-scan ultrasound is a better modality, where the choroidal melanoma can shows inner low reflective echoes because there has more necrotic tissue, whereas metastasis will show hyperreflective or moderate reflective echoes compared to a melanoma. EDI OCT is a non-invasive and very useful investigation where the few characteristics are described. It shows lumpy, bumpy appearance. There is swelling and shaggy photoreceptors seen. Subretinal fluid can show hyperreflective dots called as speckles. So always, if the primary is not known, there is very important to look for the primary. Take a thorough medical history, do a physical examination, or even a PET CT scan, and collaboration with the general physician is very important. And how to manage these patients, the decision to pursue the therapy for choroidal mets is multidisciplinary. It involves a patient oncologist and radiation oncologist, and also the overall health and life expectancy of the patient is also very important. Complex treatments are generally not advised because they have sometimes limited life expectancy, and at this point they may have synchronous other metastasis like the liver lung mets, or they may have CNS metastasis. So in case of an isolated choroidal metastasis, a local treatment can be considered upfront. But when there are multi-system metastatic disease threatening survival, then chemotherapy and systemic therapy are more essential for the patient. So systemic therapy nowadays, apart from the chemotherapy, they have targeted therapy for lung cancer, there is molecular targeting. For breast cancer, there is hormonal therapy. And if local modality are used, then radiation or external beam radiation is the most commonly used therapy, followed by plaque brachytherapy. PDT was used before, TTT, enucleation in cases of severe unrelenting pain for the patient. External beam radiotherapy is the most widely used, and 30 gray in 10 fractions is the most common dose used, but it has other side effects like radiodermatitis, focal alopecia. In long term, it can cause cataract and glaucoma. Plaque brachytherapy gives local treatment, and where an isotope is placed on the sclera to give radiation dose. It does not deliver dose outside the eye, so that can be the systemic side effects can be reduced with plaque brachytherapy. PDT, because the dry verteprofen is not nowadays available, is not used, but previously it was also used for managing small ocular metastasis. Intravitreal anti-VEGF is useful. The anti-VEGF as such, bevacizumab, was originally used to treat systemic cancer. So the intravitreal anti-VEGF monthly doses have been proven in multiple studies for reduction of pulmonary and breast cancer-induced choroidal metastasis. So when we consider the management, first thing is life expectancy. How much is what are the other metastases the patient has? If the life expectancy is short, then go for systemic therapy first, and then if the systemic therapy is not working, then go for the local treatment. If the life expectancy is better, then, and if they have bilateral disease, then external beam radiotherapy is more preferred. In unilateral cases, you can go for either plaque therapy or EBRT, whichever is. Then very rarely we can have iris and ciliary body metastasis. They can be mistaken for uveitis or neovascular glaucoma. And retinal metastasis seen in less than 1% of ocular metastasis. Diagnosis is often delayed and misdiagnosed. So thank you very much. And on behalf of the organizing committee, I would like to invite you all for Ignite 2025, which is going to be held on January 4th and 5th at Kochi. Thank you.
Thank you, Divya. Like I said, time willing, we will have the questions at the end. We always believed that our fate was decided by the stars, but now we know that all that happens to us rests in our genes. And what Sharika is going to talk about is, will genetic testing tell us not only when to expect disease, but also how to treat malignancies?
Thank you so much, madam. Thank you, madam, for insisting me to speak in this IC. And thank you all my teachers at Comtrust, Prakash sir, Vijayalakshmi madam, Seena madam, and all the others for making me who I am today. So let's get into the topic, genetic testing in ocular malignancy. So these are the topics I'm going to cover. So suppose we see an ocular malignancy. We know how to diagnose it and how to treat it. But beyond that, what is the risk of metastasis? What is the systemic surveillance that we are going to do in this patient? So that is all decided by the genetic makeup of that tumor. Okay, so what are the methods used for genetic testing, and what are the treatment modifications to be made, and a few words about prenatal genetic testing. I'll be mainly using the case examples of uveal melanoma and retinoblastoma. So the genetics in uveal melanoma mainly falls into chromosomal aberrations. That is, it can be either gain or loss of entire chromosomes, or it can be specific genetic mutations within a chromosome, or there can be differences in the gene expression, that is how the genes express in the cells, or it can be epigenetic mechanisms, that is there are the molecular mechanisms that bring about these genetic mutations, that is changes in the histone, etc. So I'll be coming to two case examples. This was patient X and that is patient Y, both having a choroidal melanoma of almost the same basal diameter but of different thickness without any nodal mets or lymph distant metastasis. So according to the TNM classification, patient X had a stage 2B carcinoma and patient Y had a stage 2A melanoma. So the TNM classification for the first patient, patient X, was the 10-year survival rate was 68%, and for patient Y was 80%. This means that you're less likely to follow up patient Y as frequently as patient X. Now let's see what was the genetic makeup of these two patients and how does it make any difference in the management. So the questions that need to be answered when you see these patients are: what is the risk of metastasis? How often do we need to do systemic surveillance? And what is the 10-year survival to offer counseling to the family as well as the bystanders? So the metastasis would have started way prior to diagnosis of the primary tumor itself. These micromets are usually not detected by the routine screening methods also. And the survival rate, according to previous studies, is almost 45% in 15 years. So the chromosomal aberrations in uveal melanoma are mostly monosomy 3, that is loss of one copy of chromosome 3 or gain of the long arm of chromosome 8. These are the ones associated with poor prognosis. It was found that having a monosomy 3 reduced the survival risk by about half in compared to disomy 3. And these are the other ones associated with poor prognosis, and these are the ones associated with better prognosis. So these were the chromosomal aberrations. Now coming to the genetic mutations that we see, just in short, that is, these are the most common genes mutated in uveal melanoma, GNAQ and GNA11, but they themselves were not enough to cause a melanoma. They could only lead to a nevus formation. Then there are driving mutations like BAP1, the BRCA1 associated protein mutation that is commonly associated with monosomy 3 and it is associated with a worse prognosis. Or there are other mutations like EIF1AX or SF3B1 splicing factor mutations which are associated with better prognosis. And BAP1 mutations are also at risk of other malignancies. Now coming to the gene expression profile. So we are learning all this because we have to do the genetic analysis of those two patients. So gene expression profiling, we use a set of 15 genes to study, and we study the RNA to see what is the expression of the cells. So they fall into two different classes, class 1 and class 2, with class 2 having a greater risk of metastasis and decreased survival rate. And it was proven in many studies also that class 2 patients have a decreased survival compared to class 1 gene expression profile. Now the Cancer Genome Atlas project combined all this, that is the different chromosomal aberrations, the specific genetic mutations as well as the gene expressions, and they classified the uveal melanoma patients into 4 distinct classes, A to D, with class A having a low risk of metastasis and class D having a high risk of metastasis. And this was highly prognostic of uveal melanoma also. Now coming back to our patients, so although they had a different TNM staging, after genetic analysis they had the same genetic class, that is they fell into monosomy 3 8q gain class with gene expression profile class 2. So how do we follow up? That is the 10-year rate of metastasis in both of them is about 60%. So how to follow up? We have to follow them up aggressively every 3 to 6 months with MRI itself. Otherwise, we might miss those micromets. Now, what are the patient perspectives towards genetic testing? In a study conducted, it was found that almost 99% of the patients surveyed found it useful. They had increased knowledge and understanding and a relief from uncertainty when genetic testing was done at the time of diagnosis of the primary tumor. So it's usually done just prior to plaque brachytherapy. Now, what are the implications in treatment? There are various therapies to prevent or treat metastasis in high-risk uveal melanomas, and notable among them is the Immunocore or the IMTAC, which is FDA approved in the treatment of uveal melanoma. It's basically a molecule that drives the T cell to act against the melanoma cell, and it was found that it improved the overall outcome and survival in metastatic uveal melanoma if given in the high-risk patients which were detected earlier. Now, Madam has already covered retinoblastoma genetics, but just to stress upon the prenatal genetic testing. So, the genes mainly involved are the RB gene, which is, we have to have a loss of both alleles of RB1 gene for retinoblastoma to happen. And the timing of the first mutation when it happens is important. A few percentage is also caused by Mican gene amplification, which is located on chromosome 2. It can be heritable or non-heritable. Heritable again with a positive family history or without a positive family history. And in heritable, the first mutation occurs at the constitutional level in the zygote and the second one occurs later. So all the cells carry the mutated allele and they are at risk of secondary cancers. In non-heritable, usually it occurs later. So the questions to be answered when we see a unilateral retinoblastoma child is the second eye at risk? So if there is an RB gene mutation, the second eye we have to follow up aggressively. Then is the sibling at risk? Again the same thing. If there is an RB gene mutation, you have to follow up the sibling closely. And what are the risk of secondary tumors? Then if we see a bilateral child, how to screen the family members is that is if there was no family history, how to screen the family members. So as Madam said, it has already been included in the AJCC classification. HX means unknown evidence of RB1 gene mutation. H0 means having normal RB genes, and H1 with a positive RB gene mutation. So now coming to prenatal genetic testing, that is the cell-free DNA in the maternal blood. That is the tumor cells which escapes from the infant in the maternal blood are studied for prenatal detection. And if we find a prenatal RB1 gene mutation, we can induce an early delivery at 36 weeks, which results in detecting smaller tumors and which can lead to simpler treatment. So this was one case example where the mother is a post-enucleation retinoblastoma survivor, and she had a baby boy, and because of prenatal testing, the tumor was diagnosed at 3 months and it was effectively treated. And this was a daughter who was diagnosed at 2 months. She was treated, although she had a recurrence, vision could be preserved well. So that is the importance of prenatal genetic testing. So to conclude, the genetic testing in retinoblastoma is mainly to follow up the other eye, for sibling screening, to explain the risk of secondary metastasis, for family planning with prenatal diagnosis, and to guide management. Thank you.
We've just got a minute to spare. So like I heard during the earlier IC, maybe questions can be asked during tea. And let me thank all our speakers, Fairuz, Viji, Prakash, Divya, and my own Sharika, who was responsible for this IC, for delivering what we asked them to do so excellently. Thank you all. Fairuz, do you want a last word a minute?
Ma'am, yeah, I mean, I just have one comment, Divya ma'am, regarding the intraocular metastasis. We always see this yellowish kind of a lesion, but there is 3 cancers which can have a reddish lesion also, which is very, very rare. Those are carcinoid, renal cell carcinoma, and follicular carcinoma of the thyroid, which sometimes, might, yeah, right, yeah. So, do you do PET scan in all these patients whenever there is a suspicion of an intraocular mets? No, like primarily if a patient is presenting with, intraocular whitish, yellowish lesion with lots of subretinal fluid, would you as a primary physician, the patient has not reached the oncologist, would you yourself go for a PET scan? Okay, yeah. So in my practice, I mean, whenever there is a suspicion of these yellow lesions, the second thing that I would do in my evaluation is to send for PET scan. Yeah, so that, from our side also we are clear whether we are dealing with that. Yeah. Great. And we also see a lot of mets in orbit. I know it was about intraocular tumors that you mentioned. Yeah, metastasis in orbit. Okay. All right. Yeah. Thanks. Yeah, ma'am, excellent. It's a pleasure being here. So, yeah, Sharika, excellent.
I think we've got to vacate the stage for the next IC.